Alberta Transplant Institute seminar. We'd like to start with a land acknowledgement. I'm very privileged that I live and work on the Treaty 6 territory, and that the University of Alberta and all of us respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all the First Peoples of Canada. That continues to contribute to our community and our efforts here in Alberta. I'd like to thank you specifically to Paladin, Astellas, and AstraZeneca for their continued support of this seminar series and for their support of the Alberta Transplant Institute in general. We're really excited about our seminar today. We have two speakers, and we're going to be visiting an area that's a hot topic in transplantation, and one that's had increasing interest over the last few years in particular. So as I mentioned, we have two speakers. We'll start out with Dr. Steve Greenway, who's a pediatric cardiologist in Calgary and a clinical associate professor at the University of Calgary. And he's been doing work on cell-free DNA for about 10 years now, and so has an accumulated expertise in this area and moving it toward actual clinical, increasing clinical practice and clinical relevance. And then we'll hear from, so he's going to give us an update on the use of cell-free DNA in transplantation. And that'll be followed by Michael Mengel, who's the chair, outgoing chair, I guess, of the Department of Laboratory Medicine and Pathology here at the University of Alberta in Edmonton, and with Alberta Precision Labs. He's studied medicine at the Semmelweis University in Budapest before moving on to specialize in pathology and transplant pathology in Hanover. And he is, his work focuses on applying molecular techniques to biopsies and working on increasing diagnostic precision in organ transplantation. And he's going to move on from Steve's work to talk to us specifically about adopting donor-derived cell-free DNA into standard of care here in Alberta. So with that, I'd like to welcome Steve, first of all, and turn it over to you, Steve. Please go ahead.
So we'll give a thanks for the opportunity to speak today, and we'll give an update on kind of cell-free DNA in transplantation. I don't have any relevant disclosures for this talk. And the objectives today is to review the background, the rationale for cell-free DNA as a marker of rejection after transplantation. We'll review some of the current state-of-the-art assays and results for cell-free DNA testing and transplantation, and then change gears a little bit and look at DNA methylation patterns in cell-free DNA as an alternative biomarker. So there are many different, types of circulating nucleic acids that we can be identified. Work has largely focused on cell-free DNA for some practical reasons, as well as its clinical utility. And the biology of cell-free DNA. So these cell-free DNA are these little fragments of double-stranded DNA that are found in various body fluids. They originate primarily from white blood cells that are undergoing apoptosis. And most nuclear cell-free DNA is about 160 base pairs in length, which corresponds to the length of DNA that's wrapped around, a nucleosome. And as that DNA and the chromosomes are cleaved during apoptosis, these fragments of DNA are released into the blood. They're fairly limited in quantity in plasma, 7 nanograms per milliliter, and they are quickly degraded as they're cleared by the kidney or the liver, and they've got about a half-life of less than 30 minutes. So kind of a biomarker of direct tissue injury can be measured in real time. And there are many origins for cell-free DNA. So even within human plasma, you have a variety of different sources for cell-free DNA, and it's not all from us. Most of it will come from our cells and our organs, various different cell types, but there's certainly representation from the microbiome and the virome, various pathogens. And then, as you know, cell-free DNA has been widely used in cancer as a biomarker for the detection of tumors. And then, as we'll talk about today, the focus on the utility of it in transplantation. And there's a variety of different processes that can lead to the release of cell-free DNA into the blood. So various types of cell death or cell processes of cell injury that again lead to the release of cell-free DNA. And cell-free DNA, like I mentioned, not just found in the blood, but can be found in most body fluids, whether it's urine, cerebrospinal fluid, or in blood. And has many utilities, as I mentioned, cancer, non-invasive prenatal testing, so for looking at fetal DNA, and then today as we'll obviously focus on transplantation, where it's gained quite a lot of traction and enthusiasm, because it provides an alternative to an invasive tissue biopsy. Interestingly, there's also some potential mechanistic roles for cell-free DNA, either as a pathological factor or its involvement in various biological processes. But we won't be touching on those today. And there are numerous factors that affect levels of total cell-free DNA in the blood, most commonly things like exercise, surgery, radiation, trauma, these kind of injuries. And it's for these reasons and the multitude of, I guess, external factors that affect total cell-free DNA that have really led people to focus on subsets of cell-free DNA. And this in particular, has led to the use of looking at DNA sequence differences in cell-free DNA. And this approach has been very fruitful in certain applications, but does limit, its applications to those situations where you have a mixture of two different cell types. So whether it's fetus and mother, whether it's cancer and healthy tissue, or in transplantation, whether it's recipient and donor. And so you can see here, that donor-derived cell-free DNA, that's kind of the main level or marker that we're interested in, and looking at that relative to the total amount of cell-free DNA, recognizing that can vary from hour to hour or from person to person, or depending on a person's exposures and circumstances. We need to kind of take the total, into account. But the application in transplantation has been on the quantity of donor-derived cell-free DNA, and that's been distinguished from recipient, usually by DNA sequence differences. And one of the first, groups out of Stanford were the first to kind of put it into the literature, recognizing that a solid organ transplant is also a genome transplant. And so, you can see here that by leveraging genotyping of the donor and the recipient, you can then deconvolute, your extracted cell-free DNA, determine your levels of donor-derived cell-free DNA. And from that, they went on to show, in this prospective study of 565 samples from 65 patients, they looked at the utility of cell-free DNA in measuring acute rejection after heart transplantation. And this was one of the first papers that kind of showed the clinical utility of this. And in cardiac transplantation, we really have lacked, a readily available biomarker, for tissue injury. So this has been, kind of a welcome advance in the field. And you can see here that, quite a bit of overlap between those who are not rejecting versus mild versus severe. But when you look at how the assay performs, in identifying severe rejection compared to no rejection, it performs fairly well. However, in more subtle differences between maybe mild rejection and no rejection, the sensitivity and specificity are not quite as appealing. And so, and after that initial paper, cell-free DNA has really kind of exploded into a variety of different trials, which has approached clinical practice. And so the standard approaches now are to extract cell-free DNA from a simple peripheral blood sample, isolate the plasma, and then separate out the cell-free DNA from that plasma, and then screening either through the identification of DNA polymorphisms, sex mismatch in a few transplant situations, or look for the presence of other genetic markers. And you can quantify the levels of donor-derived cell-free DNA using a variety of different technologies now. And again, we're monitoring the overall levels of this donor-derived cell-free DNA, and with an increase, suggesting that there's increased damage to the transplanted organ, and that's suggestive of a possibility of rejection. And donor-derived cell-free DNA, at least for the heart, has good evidence for the detection of acute cellular rejection, good evidence for the detection of antibody-mediated rejection, not so great for the detection of cardiac allograft vasculopathy, and kind of mounting evidence for the detection of allograft dysfunction. And you can see here a variety of the different biomarkers that have been developed over time, and donor-derived cell-free DNA certainly seems to be being able to provide some insight more than other ones.
Circulation 2023.
And then looking at cell-free DNA in clinical practice, focusing on the heart, these are a few of the trials that have been done over the years, and starting with that paper I first showed you by Devine in 2014 from Stanford, and then there were a follow-up study in 2019 where they used the AlloSure assay, and then a study more recently in 2022 where they used the Prospera assay. And these are kind of, my understanding, the two kind of main clinical, commercially available tests that are on the market, and you'll probably hear about a little bit more about those in the following talk. But there's been now a few trials, prospective trials, looking at the utility of cell-free DNA in heart transplantation with promising results. And other organs have also used cell-free DNA, and this is kind of a meta-analysis of the variety of number of trials in kidney transplantation. And you can see that there's overall, reasonable sensitivity and specificity, and overall, in terms of looking at it, it does seem to outperform to varying degrees just a simple creatinine measure for the detection of kidney rejection. In liver, when you look at healthy transplanted patients and those with acute dysfunction without rejection to those with rejection, you can see that there is a kind of a steady increase in liver donor-derived cell-free DNA. Interestingly, it doesn't seem to outperform ALT, which is shown kind of here in the green line, and when you're looking at for rejection versus healthy livers. And then when you're looking at acute rejection versus just plain dysfunction, like ALT, donor-derived cell-free DNA doesn't really do a great job at distinguishing between those two processes, which is perhaps not too surprising given the underlying biology of the assay. So to switch gears just a little bit and talk about DNA methylation. So, up until now, cell-free DNA's utility has been based on DNA sequence differences, but interestingly, DNA methylation is another marker of that can be leveraged in cell-free DNA. And so DNA methylation, as people know, regulates gene expression, and it's that in part which enables cellular differentiation. So it's been recognized that these DNA methylation patterns are cell or tissue specific, and these tissue specific differentially methylated regions, or DMRs, can be identified in genomic DNA. And these patterns, these DMRs of genomic DNA, are preserved in cell-free DNA. So when a cell undergoes apoptosis and the genomic DNA is cleaved, we can still identify these DMRs in cell-free DNA. And so we now have the ability to identify tissue-specific cell-free DNA molecules. And so now we're not restrained to a situation where we have a mixture of two populations. We can now measure organ injury for any organ in the body based on its cell-free DNA release, based on its tissue-specific properties. And so this greatly expands the utility of cell-free DNA as a non-invasive biomarker. And so some work that we've done looking specifically at DNA methylation as a marker of rejection after heart transplantation. So we searched and found several left ventricle specific differentially methylated regions. One for chromosome 12 is shown here, and you can see for left ventricle that relative to other tissues that the methylation profile is quite distinct. And then when we looked at the levels of this cell-free DNA marker in patients over time, we saw that it did correlate with rejection. So for this patient, they underwent transplant here, day 0, and then they had serial biopsies and simultaneous blood sample collected. And you can see that levels of cell-free DNA for this particular biomarker are relatively low with no rejection, 0R, and relatively low with just mild rejection. But with a more severe rejection, 2R to 3R, and as we label it in heart transplantation, you can see there's an increase in the amount of this DMR that we can detect in this patient's cell-free DNA. And similarly, for this second patient, we can see that there's an increase in a relative cell-free DNA of this particular population derived from the left ventricle compared to other phases of rejection. But interestingly, you'll note that the variability for 1R mild rejection is quite variable. For some patients, it's quite low, as if there was no rejection. For others, it's almost as high or higher than some more severe rejection. So that is an interesting observation and points maybe to the lack of granularity in our grading system. But this DMR does demonstrate the potential for the detection of significant rejection after heart transplantation. And DMRs have been identified for multiple tissues, so whether it's heart, lung, liver, kidney. And so, obviously we've got some work to go through. You can identify and validate these potential methylation markers. In some cases, the detection assay has been established, but now we need to establish some analytical, clinical validity, and then catch up to sequence-related cell-free DNA assays to look for clinical utility. And then just to maybe show you where the field is going. So in terms of mapping cell-free DNA and tissue injury, so now that we have markers for every tissue or cell or organ in the body, we can now, in the future, we'll be able to take a complex mixture of cell-free DNA molecules, deconvolute them, potentially for a variety of different epigenetic markers. And then, of course, it wouldn't be a talk in 2024 without mentioning AI and machine learning. But then deconvolute, the relative proportions of those cell-free DNA populations. And it was, as it was shown by this group, for individuals with flu versus COVID-19 infection, you can get a readout for organ injury for whether it's lung, whether it's heart, kidney, liver, pancreas, etc. You can kind of get a snapshot, of organ injury for an individual. And just to bring this back to transplantation, this group a couple of years ago showed that cell-free DNA, from a simple blood sample, you can obtain information both about the patient, about the donated cells, also to examine if they've if they've had a previous malignancy, and then also you can have the insight into the microbiome as well. So your cell-free DNA gives you insight into all of these different potential processes. And then they showed here that in those individuals with graft versus host disease, when they looked at a composite measure of solid organ injury, they could see that, these individuals, the GVHD, had higher levels of cell-free DNA from their solid organs, kind of reflecting the ongoing injury that they were having related to that process. So this is an application now for cell-free DNA for looking at more broadly organ injury, not just the transplanted organ. So in conclusion, so I think you've probably gathered that I do think cell-free DNA is the next best thing since sliced bread, and this is ChatGPT's version of sliced bread. And so overall, cell-free DNA is released from the tissue of interest and represents a direct biomarker of injury. Most current applications rely on DNA sequence differences, and there's ongoing differences or evaluation of this technology in transplantation. But DNA methylation promisingly greatly increases the potential utility of cell-free DNA. So thank you very much.
Thanks, Steve. And we'll move right on to Michael, and then we'll have questions at the end. Michael?
Okay, thank you, Laurie, for the opportunity to present. And thank you, Steve, for this really great introduction to what and we didn't even talk to each other, right? We didn't. It's the best things happen when you do not try to plan it. So I agree the emerging data and evidence for cell-free DNA is very, very promising. And I feel like others that now is the time that we actually learn how to use it in the clinic. And I will describe the framework we have here in Alberta with Alberta Precision Laboratories in our health system to evaluate this, and other health systems are mimicking or have similarities in how they assess new tests for clinical use. So which version are you seeing? The full screen, I hope.
Yeah, that's good.
Okay. So let's assume this test comes to review here in Alberta. And first, those are disclosures. And I will talk about these assays and have some conflicts related to the field of transplantation. And in this context, my objectives are to understand together with you the process for adoption of a new diagnostic test in Alberta. And as I said, the process has similarities to other jurisdictions in Canada, but also in Europe. The US, though, is different. To review the current evidence gaps related to the adoption of donor-derived cell-free DNA into standard of care, and to discuss the appropriate context of use for donor-derived cell-free DNA testing in Alberta in particular. I think that's relevant to this audience and what we would need to do to get to that point. So Alberta Precision Laboratories, as the lab service provider in Alberta, has, similar to the drug formulary, which our province has, a laboratory test formulary committee. And this is a committee which has developed a process for reviewing test requests to be added to the formulary or removed from the formulary, or with significant change in indication spectrum of an existing test. It is a multidisciplinary, multi-stakeholder committee, so it's not just lab folks. It also includes clinicians, representation from patient organizations, finance, Alberta Health, and the strategic clinical networks, so across the health system. Just to give you perspective, currently the test menu in Alberta has more than 4,200 tests and test codes you can choose from. Mostly they are run now through Connect Care. Approximately half of these tests, but which generate 90% of the 80 million tests done in Alberta a year, are done in-house. The other half of lower volume, more esoteric tests, especially in genetic germline testing for rare diseases and disorders, are referred out to specialty labs because they're such low volume and it would not be cost effective to do them in-house at this point. But when they become more mainstream, we often repatriate certain testing at a certain operational juncture. So the guiding principles of evaluating a new test for becoming standard of care is, of course, based on scientific evidence and following a process in a timely is relative in this, because sometimes this can get very complex because the downstream effects of introducing a test on the health system operationally are sometimes exceeding the capacity of the health system. And the formulary is tasked to be anticipating where this testing or transformative testing is taking us. And of course, maximizing effectiveness, safety, and quality for our patients, or patient-centered perspective. The patient voice in this is very important. And it is not only, as I said, new tests, but also test indications, but removal of not any more useful or appropriate tests from our formulary. And there is different categories which people often get confused about. So there is the testing, which is a so-called insured service in Alberta. So every Albertan, wherever you live, as long as you have an Alberta healthcare number, you would get access to this testing. And sometimes this testing is done by APL, and sometimes it is sent out, and APL has contracts with referral labs and pays for that. So it doesn't matter what is done here in the province, it really matters what is an insured service on the formulary. And then there is often testing which is only accessible through third-party funding, like the WCB, employers, research drug trials, foundations sometimes have compassionate access programs to certain testing paired with compassionate access programs to drugs for companion diagnostics. And sometimes the tests are again done here, or we collect the sample and send it to a contracted reference lab by these third-party funders. But we only do it for the patients who are insured in our system. We do not do patient pay or private pay testing as part of the publicly operated healthcare system at this point. The lab formulary committee, and you can go to the website and download the rapid health technology assessment and prioritization framework, which is applied to requests coming in, and which has these domains listed on the left around what the value framework and value proposition is for a test being considered as standard of care and in insured service in Alberta, which is of course around test appropriateness. So which is, how is it done, and who is it done, at what time, and what benefit does it bring when you have the test result. The system stakeholder engagement, we had, for example, a request for a new test, which had good evidence, but when we would introduce that screening test in pregnant women, we would create a significant amount of patients identified who would need to be followed up through specialty care. And there was simply no capacity to have that care pathway to all, because there's too long wait times with specialists to then further assess these patients who would be identified by the screening test. So the screening test was too sensitive to exceed capacity in our healthcare system, and therefore the test was not added to the formulary. So it is important that you not only look at what a lab can do or what one specialty area can do, but what is the referral pattern, the care pattern, who orders the test, and who follows up on the test result in the whole healthcare system. Then, of course, there is an economic impact assessment with certain willingness to pay thresholds in Alberta. So how much quality life years are gained through introducing that test. That might be a moot point if the test, for example, is a mandatory companion diagnostic to a drug, and the drug is approved, then the test gets approved, because otherwise you can't prescribe the drug independent of the test cost. And then there are equity, so access to everybody. Can this testing be rolled out that every Albertan, whether you live in High Prairie or in Grand Prairie or in Edmonton or Calgary, can get the same standard of care? Is the capacity and the operational capacity given that this testing can be, once it is added to the formulary, be ordered in the appropriate patient cohort by the appropriate providers equally? And the intake for such a test review, as you can see on the right, can be by innovators, industry, companies, clinician champions, an SCN, a lab champion. And then it flows through this review, and decision points are made about whether a full health technology assessment needs to be done, what level of evidence is required. Often the formulary comes back to the requester with a request for more data or more information, and then a review can come back. So we are not really big transformative testing like germline screening in cancer patients. Took 1 to 2 years of iterative review engagements to come to a defined patient population in which the testing is approved and funded for. So validating a diagnostic test, as Steve already alluded to, has various components. There is the analytical validity. Are you actually on an analytical level measure what you claim to measure, in this case, cell-free DNA? So does your reaction actually detect cell-free DNA and not a different molecule? So is it analytically valid? Is there clinical validity, so that when you measure differences in patients with low and high, and that correlates with your claim what it is, for example, rejection or tissue injury in this? And then there is clinical utility, which Dori Segev always calls the so what question. So now you have a result, what are you going to do with it? And what you do with it actually improves the patient experience. Whereas improvement can be in your value proposition defined differently. It does not necessarily always have to be graft survival. It could be other components of an improved patient experience. The FDA designed this standard prospective trial design, or released it on their review process website for new diagnostic tests, that you really ideally show in a prospective randomized trials in 2 arms, with the test and without the test, and then with and without intervention, that adding the test here improves the decision making of intervention, and then doing the intervention actually improves your primary endpoint. And doing that then depends on the context of your health system and what your value framework is for reimbursement and funding. And this can be different in terms of your jurisdiction. So Alberta has a different willingness to pay threshold than other countries like Scandinavia or the Netherlands. And also the United States has a different reimbursement strategies and approval processes. So ideally, you have a test which generates more health for less money spent on the testing and the care of the patient. That's the very good one. However, there are many tests out there which cost more money and do not produce more health at best, and some which actually produce more cost in the healthcare system with false positive or false negative results. And for cell-free DNA, as Steve showed, is saying there's promising data, but still when you look at this graph about the sensitivity and specificity from all these different studies in this review paper, there is a large spread of inter-study variability in how sensitive or how specific these tests have been in this context of use of these study designs. And then when you start reviewing this, it comes to the devil of the detail, saying what was your study cohort, what were the time points, what was the correlation point, what was the power of the study, which could all influence the sensitivity and specificities they calculated for that specific publication. But that is always a concern when you want to make it standard of care, when you want to develop reference ranges and cutoffs which trigger specific clinical decision points. And this has all been nicely summarized in this review. What are the gaps and pitfalls still in the unanswered questions? And I will in the following try to go into a little bit more detail of that, because this is the current task for one of the STAR, Sensitization and Transplantation Assessment of Risk Working Groups, which has developed over the last couple of years under the partnership of ASHI and AST and the Canadian Society of Transplantation and the Band Foundation for Allograft Pathology, standards around donor-specific antibody, first anti-HLA, now anti-non-HLA antibodies, the standards around defining the clinical validity and also the clinical utility of that kind of testing and risk assessment of transplant patients. And at the last round of the executive of STAR, it was identified that donor-derived cell-free DNA fits into the same portfolio of a risk assessment tool of patients post-transplantation at this point, and can be a complementary tool of a minimal invasive test like antibody testing for non-HLA and HLA antibodies, or the assessment of presensitization and immunogenicity in transplant patients. So the STAR group commissioned a working group focused on donor-derived cell-free DNA, which is led by Nicole Valenzuela, and the members are listed here. And this group developed an outline really around the basic work of the next step of how taking or creating the foundation, how to properly adopt this type of testing for donor-derived cell-free DNA into a clinical grade laboratory across all our transplant centers. As you remember, when DSA organically grew across transplant centers, there was no real harmonization and standardization. Results are still difficult to compare. And this group tries to get ahead of that and to abbreviate the process to end up on a more standardized testing framework so that results amongst laboratories and transplant centers are comparable. And this starts with pre-analytics. So what samples are you requiring? What's the volume? What's sample stability? How do they have to be shipped? What are risks for sample confounders and deterioration? So this is all nitty-gritty lab staff. And what are the analytical frameworks? What is the proficiency testing framework? So the quality assurance framework of doing this testing. Currently, the testing is done for commercial kits in centralized labs, which standardized it for their lab. but there is a development that kits will come to market that every transplant lab can do it. And there are different assays, as Steve pointed out, NGS-based, PCR-based, digital PCR-based. So how do we make them comparable? What are the reference ranges for them? And how do we quality control them that a lab actually performs the test accurately? This is bread and butter work for clinical laboratories, but it needs to be developed and standards need to be set for every type of testing in the respective context. And then the clinical validity scope and validation and framework and guidelines, it is, so how are other factors like drug toxicity, infection, comorbidities, organ type, organ size, multiple organs influence the test accuracy, the test sensitivity with confounders and specificity, and what are the safeguards to identify false positive, false negative tests in a regulatory and accredited laboratory. All those have not been established yet in the literature or in any guidelines. And then the question around the clinical context of use. So is it a test which is of more accuracy in the heart because the heart or the liver, they have a lot of parenchyma? Is it different in the lung? Is it different disease versus living related donors? Do we need different reference ranges in those? What is in multi-organ recipients or retransplants? What is in patients who have recurrent disease, releasing tissue injury? How is that related in the reference ranges, or is this a disclaimer in when you read the package insert of the test, high donor cell-free DNA only points towards rejection under these circumstances, for example? Or is it a test which only says when high, do a biopsy? No other claims made. So that's the context of use where we have yet no consensus or harmonized standards around this as well. And then the clinical utility really is the big question remaining. And is this test of value? And again, value is in the eye of the beholder. And for sure, when you ask heart transplant patients, and currently in some centers, they get up to, I heard, 10 biopsies in the first year. And then if you can spare 7 of those through cell-free DNA testing and stable, then of course the patient experience is great. But other centers, I think, only do 5 heart biopsies in the first year. So it really depends on your context. Then the gain to the patient becomes less when you only can reduce it by 1 or 2 per year in average. So learning about the context of use is really, I think, only possible through well-designed trials, ideally prospectively. And the rationale for doing this and starting this now is really that up to now, these tests are done at centralized reference labs, but there will be commercial kits available like it is for TSA testing. The technology we use in our HLA laboratories for high resolution testing is marching towards NGS and high resolution PCR technology. So the platforms you can run cell-free DNA, donor-derived cell-free DNA on are clinical grade standard platforms in HLA laboratories. So there is an HLA get the similar samples and the similar time points for DNA testing, DSA testing. So you can pair up collections, sample logistics to add on this test to the menu operationally in HLA labs. And there might be, of course, the advantage to interpret the results in the same context, as we have seen from recent studies that especially in antibody-mediated rejection and the precursors to that, cell-free DNA seems to be a very promising screening tool. So under the leadership of James Land from UBC, a proposal has been developed for a pan-Canadian prospective randomized trial to assess the clinical utility of cell-free DNA. This proposal is currently under review by CIHR for funding, and there is a commitment from a trial sponsor from the industry side to support this for the matching of the funds required or requested from CIHR. And the study group developed the inclusion and exclusion criteria as spelled out here, and has defined the endpoint. So really the primary endpoint is to show that using this test improves graft function, with a GFR improvement as the surrogate endpoint, and not graft failure as the primary endpoint. And secondary outcomes is, of course, detection of rejection, subclinical rejection, graft loss if it occurs, and precursors to de novo donor-specific antibody, as well as the patient experience as in a secondary analysis point, the physician experience, and a health economic cost analysis. That is the overall trial design. So enriched and powered for 800 patients over 2 years at a population at risk, and randomized for getting cell-free DNA or standard of care. And then within cell-free DNA, abnormal cases would get a biopsy, and then the endpoints of the 2 approaches of management would be compared after 2 years. So it really, the hypothesis is that an abnormal cell-free DNA triggers a biopsy and triggers this biopsy earlier, and this earlier biopsy allows us to do targeted intervention as far as we can. And we all know many diseases we have no good interventions, so therefore it might well be that at the end we have no benefit because we detect something earlier, we can't do anything about it. And the numbers and the powers are here to show that when you do this in the interventional arm, it's 13 tests in the first year. If you do it in the normal cell-free DNA non-intervention arm, it's up to 9 tests. So it's a huge number of tests because when you don't do it, it's a bit like Donald Trump: don't test for COVID, then there is no COVID. Don't test for rejection, then there is no rejection. But therefore, this monthly testing schema to not miss anything in between. So to this point, the so what question remains. We tell all our trainees, don't order lab tests if you do not know what to do with the result. False diagnostic claims of a test, so over-promising results, can cause patient harm, as we know, but also not doing the right test at the right time can cause patient harm. And we know that we need better diagnostic and risk prediction tools, but still many diseases we face in transplants, we do not have effective targeted treatments. And that's the difference to the cancer story, where you measure that 1 point mutation in the liquid biopsy, a BRAF mutation, and you have an imaging a glioblastoma or melanoma, and you give the anti-BRAF drug and the tumor instantaneously responds. Unfortunately, our cell-free DNA neither carries disease-specific information because it is just DNA from the graft, which can be released due to various reasons. And it also does not carry the information of a targeted treatment as it does in cancer. So I think we need to be more thorough around our next step in data generation of defining the accurate context of use for this very promising biomarker. With that, I'm done with my slides, and I'm looking forward to the discussion. Thank you.
So we've got some time for questions now, which we can open to the audience. But I wonder, Steve, if I could go to you first and see if you have thoughts on this kind of very interesting description of how one moves a test forward into clinical use.
Yeah, no, that was a great talk, Mike, and it's a high bar, to reach, right? And there's certainly a lot of, I think that's part of the messiness of cell-free DNA, unfortunately, right? Is that it is fairly non-specific, and there's a lot of different reasons why you can detect, an increase. And, certainly from a heart point of view, like you said, the sparing the patient the biopsy is certainly the most compelling, argument. Can we, and then I guess then it comes down to kind of cost benefit and patient, benefit analysis. But yeah, probably still some more work to do. Though I think maybe from a heart point of view, there seems to be a fair amount of data there. I agree. For the other organs, particularly when you have a biomarker that works reasonably well, then maybe there, the arguments are a little bit stronger, or the evidence, the bar to implement it is a bit higher. But maybe heart might lead the way in this regard, just to kind of catch up with the other organs.
Yeah, well, I know that the Paris group, which does protocol kidney biopsies, is doing the design like the heart people did, is can we spare these protocol kidney biopsies, right? That's a low-hanging fruit. It's a patient experience improvement and likely a cost benefit when you have decentralized kits and you can do this test in-house for, I don't know, $250 like a DSA screen. Then suddenly the value proposition to not doing a heart catheter and taking biopsies wide with all those risk complications becomes a no-brainer to me, and it doesn't matter. You just need to show it's safe, so to say, right? When you only are on cell-free DNA monitoring and you don't get rejection for whatever reason you would have detected, but I doubt it in the heart, right? But I think that's a quick win, and it's a different value proposition, like a diagnostic claim saying, oh, I know this is ABMR and I don't need a biopsy and I just treat it, right? So that's a you're right.
I think Phil has a question.
He has a hand up.
He has a hand up. Phil?
You're muted in case you're talking.
Yeah,
No.
sorry. Thanks very much, Michael and Stephen, for this. I think it's very useful. One issue which sort of complicates trial design and evaluation, as outlined by Michael, is that, for example, we're going to have new treatments for antibody-mediated rejection. We're supporting the trials, and I think we're actually going to be able to start treating. Up till now, essentially nothing works. But once we can see this, and it's a common disease, and we can screen for it and then intervene, we then have to have a test which we are confident is saying what the effective treatment is. So cell-free DNA is not just for diagnostics, it can be for following patients and evaluating the effective treatment. And I think you'll see that that's the way new trials are being designed. But in treating antibody-mediated rejection, Michael, you're not going to see a change in GFR. You're going to see what you're trying to do is extinguish activity, and the change in GFR is over a much longer time. So I think that as the trial is set up, one should be more focused on disease activity and less focused on change in function and outcome in the time frame that we have to evaluate things. I think if you just focused on change in GFR, probably you'd see a failure. But if you focused on disease activity, that would actually see a benefit. And the other thing, just as a former clinician, I would say that there's a benefit to knowing what's going on with a patient, regardless of whether you can directly show that you can change an outcome. So I think that you may be underestimating that benefit for the clinician of knowing what's going on, and also for the patient knowing what's going on. And that should probably be part of your trials as well, not just objective measures of theoretical outcomes, which in transplantation almost nothing has done for the last 20 years, but actually benefit of knowing the truth. So 2 points. One is the cell-free DNA is probably going to be a more useful tool in monitoring the patient than you've estimated so far. And secondly, there's more benefit to some of these tests than maybe your trial is assessing. Just one other point. There's a big problem with kits. And Michael, you know this very well, and with standardizing kits and local use of kits has produced unreliable results. And one hopes that cell-free DNA doesn't go down that road. So maybe how are you really going to address that?
Well, that's the work of the STAR group, right? I don't expect that you can compare digital PCR to NGS-based assays. And that's the reality. So when we have many assays in the lab, which can be done on different platforms, and different platforms require different reference ranges. We don't have yet an international standards institute like chemistry has, which agrees on conversion formulas with international standards. So maybe that is a way we can go to make kits quality controlled and comparable, that we have spiked quantities of third-party DNA in every kit, which is a standardized quantity everybody measures, and you know that's your your quantitation benchmark. So kits like that exist. It's expensive to build them, so it becomes a market value question. How much do you want to pay for a kit, and how much do you pay for this assay? Is the market big enough that somebody produces these kits at that level of quality? But it is technically possible to standardize kits and platforms. It has been successfully done.
You mean so that when someone says copies per mil with one assay, they will be getting the same number with various kits, and that you think that's achievable?
No, what we do is you get a different number, but there is a gold benchmark standard, which everybody runs as well. And then you build into your analyzer. That's how creatinine is done. So we have Roche, and Saskatchewan might have Siemens analyzers for creatinine. And they get a different number of the machine, but then there is a standard you use to calculate a conversion factor to report it on international units. So that's a common practice. So you can have different vendors and kits and platforms. You can either say every kit has a different, we have that as well. So we say we use this troponin, high sensitive troponin assay. This is our reference range. That's different from different hospitals. So we had, for those, the interested reader, in Alberta, before we went to Connect Care and one lab provider, we had, I think, 6 different troponin assays in community and everything. And tracing when a patient got referred was impossible. Like same with beta HCG. So you could, it really depends. There's various ways how you can standardize these kits, whether you want to do it locally or nationally or internationally is, yeah.
Just a follow-up question for Stephen. In relationship to how the measurement should be expressed, it started off by being measured as a fraction, and clinically we should never use fractions because the numerator and the denominator can change. So we should be moving toward copies per mil. And do you think that's the way we should go? Our studies would indicate that copies per mil are probably a little bit better on average than using the fraction, since the denominator can vary with, for example, COVID or something.
Yeah, no, absolutely. And that was one of the things that we showed. And the reason why we kind of broke it out by individual patients is because, you know, that fraction, as you said, was so variable between individuals. So that was another challenge, you know, let alone differences between laboratories or different assays, you know, differences between individuals is very challenging. So yeah, some kind of, I guess, some kind of measurement system where you can hopefully kind of eliminate that variability or make numbers comparable between individuals would be very, very helpful. I agree.
But to Phil's point, even the absolute number could be variable if you transplant a 2-kilogram liver or a pediatric heart, right?
Yeah.
Doesn't that correlate with mass of release?
Yeah.
And I think people are trying to do that is to get standardization organ by organ.
What?
Well, it wouldn't be just organ by organ, wouldn't it? It'd be also by size and by ischemic time, maybe. Well, maybe not in the.
No, or does it matter, right? So this is what we don't know. So let's assume a 2-kilogram liver produces more cell-free DNA in a normal state than a 500-kilogram child liver, right? Let's say. So the so what question of clinical utility is, it could be a reference range from 1 to 50, and everything above 50 is abnormal for pediatric patients or adult patients. So that could be the answer. Or it could be everything doubling of your background release is abnormal, right? And then you need to have patient-specific baselines. That's also for some assays, is that every patient has established, like when you monitor after treatment double-stranded DNA in lupus, every patient has serial measurements to establish a baseline of quiescence on the health record, right? Same test, right? It's all context of use. And we don't know that. We have a measurement here. We know what a meter is, but measuring a meter in in certain contexts is a different implication, right? So
yeah, no, that's interesting. But like you said, if you're going to be doing 13 tests over a year, you know, or more, you know, then maybe individual, you know, standardization is feasible or reasonable. in that regard. If you're doing enough of the test and over the lifetime of that individual, right? Is it going to stay relatively static, over time? Maybe, maybe not for a child, but yeah,
That's what we do
those
with
are
creatinine.
interesting thoughts.
That's what we do with creatinine. Every kidney transplant patient has an individual creatinine range, right? It's never the same, to Phil's point. Big donor, small organ, right? Big recipient. So but can we afford? We can't afford a $3,000 test every month. So it comes down to, can you do this? A creatinine is 70 cents.
How much does a cardiac cath cost, though, with all the things considered?
Yeah.
Kieran's got his hand up too. Kieran, did you have a question?
Yeah, hi. I just wanted to also raise the question about organ-specific kind of considerations. In lung, we have multiple forms of graft dysfunction, which will produce inflammation and cell-free DNA release, but multiple forms of graft dysfunction which will not, like large airway dysfunction, bronchomalacia, obesity, probably fluid overload. So one really, I think promising aspect of this for us, which I think will be hard to demonstrate in a clinical trial, will be distinguishing those forms that don't release cell-free DNA from those forms that do. And so, I would worry about, a funding consideration where we're being held to the standard of improving kidney transplant function, when there may be other organ-specific use cases, which I think would help us with treating people.
So yeah, okay, sorry for the confusion, Kieran, right? Every organ needs, in heart, the value proposition might be saving biopsies, right? That's a different adoption decision. But then the test would be on the menu, cell-free DNA heart. So not a nephrologist can't order it. So the problem we have in Alberta is once it's a test code in Connect Care, almost everybody can order it in whatever. So you will be surprised. People will order it in non-transplant patients. So it is, so we need it defined. What I try to say is you need your defined context of use and care pathway and use case. It might be totally different in lung, as you say, right? It totally, yeah.
Okay. And would we work with sort of you to develop those or locally and make the case, or how would that work?
Yeah, that's a good question, right? You're a small group. I would say that's why we joined this national effort. It's always better to have a national guideline, or ideally an AST guideline you can reference, but show in the Alberta context. That's the best recipe. National, international guidelines, and you show some preliminary data or the Alberta context as the real world evidence, so to say, and then you come to lab formulary and start this iterative approach.
This has been really interesting. It's so interesting to have included both the background and the current work that Steve's doing, as well as the practicalities of moving something forward in Alberta. So I'd like to thank you both. I think this has been really a great seminar. I'd like to also let everybody know that we have an unusual seminar next week. We have a hybrid seminar session with a visiting professor, Konrad Hutzenecker from Austria, on the use of post-op prolonged ECMO in PAH patients. And this is going to be at 7 a.m. The seminar is at 7 a.m. There's no noon seminar next week, and it's going to be a hybrid event in person. People can go to Bernard Snell Hall at 7 a.m. for that presentation. We really encourage you all to come out. It's really nice to have a visiting speaker coming from Europe. And I'll just end then by thanking both of our speakers today, as well as people who were engaged in the discussion. This has been a really, really insightful session. So thanks a lot very much.